All right, hi guys, welcome back. This is Casey and Salia, and we are so thankful that you are tuning back into NSIGHTS, which is a podcast based on content from On Call, which is a continually updated textbook from the Neurocritical Care Society, which is available online. We are so thankful for our sponsors, Cerebell and Biogen, and now a word from our sponsor.
Founded in 1978, Biogen is a leading global biotechnology company that has pioneered multiple breakthrough innovations, including a broad portfolio of medicines to treat multiple sclerosis, the first approved treatment for spinal muscular atrophy, and 2 co-developed treatments to address a defining pathology of Alzheimer's disease. Biogen is advancing a pipeline of potential novel therapies across neurology, neuropsychiatry, specialized immunology, and rare diseases, and remains acutely focused on its purpose of serving humanity through science while advancing a healthier, more sustainable, and equitable world.
But stroke is the result of reduced blood flow to brain tissues. And although mortality is not as high as intracranial hemorrhage, in our country, the mortality can range from 10 to 20%. And Casey, could you please help us with the diagnosis and walk us through how you would diagnose someone who comes to the ED with possible signs and symptoms of ischemic stroke?
Yeah, absolutely. So I think stroke can be tricky because so many presentations and almost any acute onset of neurologic deficit could be attributable to an ischemic event. However, time is really, really brain here, and that many, many millions of neurons can die with each minute of delay. And there are 2 forms of treatment, thrombolysis and mechanical thrombectomy. And so I think it's really important to think about who qualifies for those and how you can identify those patients. Because unfortunately, a lot of our patients present outside of the window for treatment or don't have a large vessel occlusion and therefore don't qualify for thrombectomy. So let's talk about first those patients that do present with a large vessel occlusion, because I think those are the ischemic syndromes. So it's critical to recognize these. So large vessels include the ICAs, meaning the internal carotid arteries, the MCAs, the middle cerebral arteries, and the basilar artery. The first 2, the ICA and the MCA, are part of the anterior circulation. And that's where we actually really have the best data for thrombectomy. The basilar is still a large vessel, and we are pushing more and more for these patients to get thrombectomy, but the trial data is most robust for those anterior circulations occlusions. So fortunately, these ICA and MCA occlusions have a signature, right? So these are the patients who typically come in with a gaze deviation, which is going to be to the side of the ischemia, as well as contralateral weakness, and either aphasia, if it's a dominant MCA syndrome, or neglect, if it's a non-dominant MCA syndrome. And so that's a syndrome that I think all providers should really have grilled into their head about, like, that's the patient that's probably going to qualify for thrombectomy, and that's the patient we really need imaging as soon as possible. Now, basilar thrombosis is really challenging. I think there is a clinical delay in recognizing these patients, and it really requires a very heightened level of suspicion. So I think of these with patients who have gaze paresis or any change in alteration of consciousness that happens pretty acutely. Ask yourself, could this be a basilar thrombosis? And to really examine that patient for either asymmetric weakness or maybe a gaze deviation or with any sort of changes in their pupillary findings. This can be subtle, but I think those are the patients that we really need to be most attuned to finding, because those are the patients that are going to have the highest mortality and morbidity, and those are the patients that can be helped with treatment.
Great, interesting. Now, given all these challenges and unknowns, can imaging help us here?
Absolutely. So imaging is crucial in the workup for an acute stroke. So again, I think the 2 things that every patient really with an acute stroke syndrome needs to have done are to figure out, 1, when was the time that they were last seen well, right? That's going to determine, does this patient with neurologic symptoms, do they qualify for thrombectomy? And then they need to get to the scanner, right? To qualify for any treatment for ischemic stroke, you have to, 1, have no blood in your head. And two, if you're going to be a candidate for thrombectomy, you have to have one of those large vessel occlusions. There are two imaging sequences that patients that have acute ischemic changes really need. One is the non-con head CT. That's just to rule out blood in the head. And then patients need vessel imaging, right? And that's going to be with a CT angiogram, head and neck. We want both the head and the neck because the neck can give us a lot of information about A, if there's a internal carotid occlusion, or B, if there is some sort of like critical pathology, like a dissection or very unstable atherosclerosis in the neck. Like that will help us identify like what was the etiology of a stroke. So to summarize, for any patient who's presenting to the emergency department with acute onset of focal or lateralizing neurologic deficits, that patient deserves a CT and a CTA head and neck up front. For the sake of time, we're going to skip over kind of the CT perfusion and how that plays into the neurologic evaluation for mechanical thrombectomy. What I will say for all trainees and for emergency providers is talk upfront with your stroke team when you're getting this imaging. Hey, do you guys want the CT perfusion if that's available at your center? It's really important to make that decision before you get the CTA. For mechanical thrombectomy and who's going to qualify for thrombolysis. And so maybe walk us through, Salia, a little bit about the mechanism of action for thrombolytics and sort of the inclusion, exclusion, and some of those pertinent must-know for that sort of treatment.
Sure. As you mentioned, a lot of these patients are screened and monitored to see if they qualify to get a thrombolytic or not. I'm going to start off by saying what these agents are, what they do, and then we'll walk through, okay, like who can get it, who shouldn't get it, and all of that. So I think the agent that most of us are more familiar with is alteplase. I'm not going to use TPA anymore just because we have tenecteplase now and it's going to be really confusing. And I encourage everyone to just say alteplase or tenecteplase to make it very clear for everyone who's working with you and your team. So both of these agents, what they do is that they are local thrombolytic agents. Convert plasminogen into plasmin, and plasmin really converts that or breaks down that clot or fibrin that is associated with the clot. We do talk about, these patients need to have a blood pressure that can tolerate that thrombolytic agent, because if the blood pressure is very high, they can convert that to a hemorrhagic stroke. So the threshold that we consider safe for these patients is systolic of less than 185 and diastolic of 110 before giving it. The other thing that we obviously look at and think about is that what is their blood sugar, right? Because we know that low blood sugar and high blood sugar can look like stroke. So that's really one lab that the guidelines are recommending we check before giving alteplase or tenecteplase, and we'll talk about tenecteplase a little bit later. Other labs that we look at, I know that a lot of people really emphasize on platelet count and INR and things like that. I do want to highlight that you really don't need to send for those labs unless you are concerned for coagulopathy. So in a normal, healthy individual, waiting for PTT or INR or platelet count to come back is really a waste of time. As far as, tenecteplase, we are now seeing a lot of interest for using tenecteplase for acute ischemic stroke. To give you a little bit of background, there are some initial historic studies that looked at tenecteplase in patients who had large vessel occlusion and needed thrombectomy. And those studies, actually, although smaller studies, they showed better functional outcomes than alteplase, which was really interesting to see. More recently, the ACT trial, which is a multi-center, much larger study, was published, and they actually found that even in the majority of those patients that didn't go for thrombectomy, the functional outcomes and the safety outcomes were pretty similar to alteplase. Hypothetically, tenecteplase has a shorter half-life, so it's just an IV push as opposed to a push and a continuous infusion. So we love that for that. It's just a one shot, you give it, it's an IV push, so it's easy, less resource, intensive. The other thing is that because it's more fibrin specific, hypothetically, it has lower risk of bleeding. Although studies that are published, they're talking about similar risks of bleed as of now. The common dose that we see for ischemic stroke is 0.25 mg per kg, maxing it at 25 milligrams. Remember that the vials are 50 milligram vials, so you always have some waste.
Are switching to this because of the ease of dosing, the quicker administration. It's kind of one shot and done. The one thing that I saw one time, and I think it's just worth noting, is that because it's a one and done shot, you actually really need to have a good caliber IV. This is not something that you want to be pushing through like a 22 in the hand that's going to get infiltrated, because this is your one shot. And so yeah, I also wanted to ask you, because I think this is coming up more and more clinically. So many more patients are using DOACs now. And so what should I do if a patient who's reportedly on a DOAC now presents with signs of an acute ischemic stroke?
Yeah, very good question. As you said, a lot of people in the community are on apixaban, rivaroxaban, not so much on dabigatran anymore, but just speaking of DOACs as a class, I think the first question that you should ask yourself is, when was the last time that they took the medication? And the second question you can ask, and hopefully you have more information on that, what is the renal function? Obviously, if the renal function is poor, then that 48-hour could possibly be extended to 72 hours. And in patients who are getting dabigatran, because of how extensively it's cleared renally, that could be also extended to sometimes 4 or 5 days, which obviously could be a problem.
Gosh, so it's really like checking in with the family, trying to find when their last dose is, and confirming, obviously, if they're reliably taking it, this is not a patient that qualifies for thrombolytics.
Correct.
So then what if someone is on aspirin, or if they're on DVT prophylaxis? What about that?
Sometimes we get questions about, oh, this patient's on aspirin. Aspirin's okay. This patient's on sub-Q heparin for prophylaxis. That is okay. If someone's on prophylactic dose of Lovenox, again, on the floor, that's all okay. It does get, again, problem if someone's on therapeutic doses of heparin or Lovenox, but prophylactic doses of these agents that we commonly see on the floor for, DVT prophylaxis or aspirin, those are okay to, go ahead if they meet other criteria for alteplase administration or tenecteplase administration. That's okay, and you can go ahead and do that. But to
Okay, so you've determined, like, based on, the patient walks in, you have no reason to think that they have a coagulopathy. It's a run-of-the-mill patient. You check a finger stick blood sugar and it's, 135. And so you're going to go ahead and give them thrombolytics. Great. So what are some of the side effects that we need to watch for after we've given these?
Sure. Two things. I think I'm going to start with the bleeding risk. Obviously, it is very thoughtful and reasonable to think about bleeding if your patient's complaining of a headache, or you see worsening of the exam as you're giving your thrombolytic, whether it's alteplase or tenecteplase. As far as what you do if they bleed, let's say they complain of a headache and you stop the alteplase infusion, or it's already, the tenecteplase is already given. You go for a HET CT. If they have a hemorrhagic conversion now, obviously, what you want to do is that try to provide them with the fibrinogen, because these people are going to be deficient in fibrinogen. Cryoprecipitate is the agent of choice to treat these patients with in the setting of this hemorrhagic conversion. Usually we talk about 10 units. People do talk about, in the guidelines, also talk about you could send for fibrinogen levels in these patients. If it's less than 150, you could give them additional doses for that. So that's really what we think about when people bleed on thrombolytic agents.
Yeah, I kind of think of it as being like sort of in an iatrogenic DIC picture for almost that first 24 hours. I mean, even though the half-life of these drugs is very short, the actual effect on the fibrinogen levels can last a long time. All practice is to tell people, the second you see that ICH, get the 10 units of cryoprecipitate, but also send that fibrinogen level so that it's cooking. Don't wait for it to come back. Go ahead and give them that 10 of cryoprecipitate, and then you can always give more based on the level.
Correct. No, that's a very good point. And that's when we talk about pharmacokinetic versus pharmacodynamic half-life, that the drug itself will be out of the system, but the impact of the drug on the platelets and the coagulation cascade will still be there. Now with the angioedema, I think, again, there are certain patients that are at higher risk. I think African Americans, patients who have had angioedema with ACE inhibitors are typically the patients to think about when you're giving this drug and you see those signs of angioedema. In terms of what to give in this case, thinking about hypersensitivity reactions, right? So in the American Heart Association guidelines, they talk about giving methylpred 125 milligrams. They talk about giving Benadryl 50 milligrams, all IV formulation, just because of the quick onset. Ranitidine or some sort of H2 blocker, just to, block the histamine release. Now, if things get worse, obviously, and they are progressing, that's, I think, when we think about intubating, giving epinephrine, kind of like how we're treating anaphylactic, episodes and reactions. So those are some of the clinical pros to kind of think about when we're going through angioedema with these patients. And the other thing is, if they're on an ACE inhibitor, obviously you want to make sure that you hold that and you're not reintroducing ACE inhibitor for these patients.
Yeah, absolutely. It's not one of those things that you commonly encounter, but man, when it does happen, it can progress quickly. Fortunately, I've seen, kind of over the next couple of days, it does sort of reside on its own. So many pearls and so much to think about. This is a really common and a diagnosis that I think that we can really do a lot of good by just acting expediently and as a team and trying to get patients into the center as quickly as possible. So the couple pearls to leave you with from the clinical side are really establishing that last seen well, because that's going to be really crucial in dictating what kind of therapy the patient's eligible for. The other thing is look for an LVO syndrome, like look for that gaze deviation, contralateral weakness, neglect, or aphasia. Those are going to clue you in that this patient might qualify for mechanical thrombectomy and needs to be expedited through their imaging and to a thrombectomy capable center. Time is so critical, establishing if the patient is TPA eligible. Don't think about it in terms of like, oh, well, they are within 4.5 hours, we have time. Like, no, you don't have time. So don't delay to get information that you don't really need, and never ever delay a CTA for renal clearance. Salia, from the pharmacokinetic and all the pharmacology pearls, things to leave?
Sure. I think I wanted to re-emphasize that time is brain. So I think that's maybe the beauty of tenecteplase, that, it's a one shot, it's faster. You don't have to get a pump. You don't have to, go through, 10% bolus, 90% infusion. And that is the key here. I think just making sure, checking blood glucose before, giving alteplase or making that diagnosis, making sure that we're familiar with, how these agents work, what to do when they bleed, what to do if they have angioedema. And also, making sure that as much as we care about, giving this agent, we want to make sure that we provide the right care after they get that. So blood pressure monitoring after you give alteplase or tenecteplase is as important. We talk about for these patients, keeping the blood pressure less than systolic of 180 over diastolic of 105 for the first 24 hours.
Absolutely. All right, guys. Well, that is all for today, and we look forward to seeing you on the next episode. Thank you again for tuning in, and make sure you check out the on-call chapter, which you can visit by going to neurocriticalcare.org, checking out the education tab, and you can find it within the on-demand resources. All right. Thank you again.
Bye.